We're all live. Welcome to Project Pivot and our session. We're going to get started. Let's give people one more minute and then we'll get going. So come in, everybody, if you want to be engaged with our Project Pivot today. And I don't see anyone new walking up, maybe a couple people. Okay, Sue, Debbie, are you ready to go? Okay. Welcome, everybody. We are going to engage you today. Our ultimate goal is to generate new HCAHPS questions, and we want your feedback in doing that. So we'll do a little bit of Slido at the very end. You might want to just make sure your phones are handy. We won't get to that for about 20 minutes yet, 15, 20 minutes. Okay, I'm Marty Hatlie. I'm a patient safety activist. My colleagues are Sue Sheridan and Divvy. They're going to introduce themselves as they kind of take the stage, but please join me in wishing Sue Sheridan a happy birthday today. Today is her birthday. We are PFPS US, that stands for Patients for Patient Safety US. We're the US branch of a global network that is affiliated with the World Health Organization. Our goal there's a global patient safety action plan. Our goal is to see it implemented in the United States. It maps very, very closely to the national action plan we have here. We do a lot of work trying to prioritize patient safety in the public policy arena. We do a lot of work in Washington. And we're also very, very interested in what patients would report and how patients can become part of our learning system. And that's really what the focus is of Project Pivot, which we'll be talking about more today. You can join Patients for Patient Safety US as an organization or as an individual. If you're an individual, you become a patient safety champion. There's two criteria. You have to be passionate about working with patients and families, and you have to be passionate about patient safety. We're patient-led, but you don't have to have lived experience as a patient to join us. You just have to be passionate about working with us. We're going to start with a quick video here that will bring some of the other voices that are part of our community. We have 150 patient safety champions across the country right now. We're growing. We orient 3 times a month. You can join us anytime, but here are some of our champions and some of their experiences that are really pertinent to our work today on diagnostic safety.
You know, I live with 2 words, if only.
My name is Lieutenant Colonel Stephen Coffey.
My name is Kimberly Roger.
My name is Jeanette Averett.
My name is Sarah Keel.
My name is Desiree Collins Bradley.
I'm Susie Becken.
I experienced a diagnostic error.
My son, Stephen Coffey II, experienced a diagnostic error.
I experienced a diagnostic error.
My son, Chad, experienced a diagnostic error.
My 11-year-old daughter, Deance, who is medically complex, experienced a diagnosis error.
I experienced a delay in diagnosis of a serious, life-threatening sepsis caused by a routine laparoscopic hysterectomy.
His metabolic condition, galactosemia, was not fully explained to us as parents or among the military staff at the hospital.
I was told I needed to scale down my stress, so my doctor set me up with clinical massages, anger management, and even a nutritionist.
The appropriate workup for my anemia was not recommended.
When I saw the surgeon with symptoms of infection, it was not investigated and missed.
Deance went almost over a year being misdiagnosed.
And 1 week later, he had a liver transplant. What if the doctors who had told me on the phone my son had galactosemia clearly articulated the severity of his condition?
Nevertheless, I suffered a stroke a few months later at the age of 42. What if my doctor had prescribed a carotid artery examination and a full physical?
This resulted in the delay in my diagnosis of stage 2 colorectal cancer. What if appropriate diagnostic tests had been recommended and performed in a timely manner?
This delayed finding and treating an internal abscess, which in turn resulted in a massive hemorrhage and led to 2 emergency surgeries and septic shock. The impact to my family is immeasurable. What if my surgeon had done blood work or investigated my symptoms when I saw him in the office 3 weeks after my hysterectomy?
She actually had an antibiotic-resistant infection called serratia. She has permanent lung damage. My what if is, what if her primary care physician had not been in her tunnel vision of this is just a routine infection that Deance always gets, and had consulted her other specialists, and B, had ordered further testing a whole lot sooner.
Chad was misdiagnosed 3 times in 1 year. He was ultimately diagnosed with stage 4 colorectal cancer. At the age of 37, Chad died after 16 months of treatment and painful side effects. What if the proper tests were done initially for an accurate diagnosis and treatment initiated earlier? Then maybe he would have survived.
Okay, I don't know if you noticed, but the person who edited that, his name was Sheridan, same last name as mine. That's my son. What brings me into diagnostic safety, and I have been in this space for 30 years, was when Cal was born, a normal newborn. His newborn jaundice was never tested or treated in time. He was misdiagnosed for 5 days. We watched him suffer brain damage in the hospital. That brought me into this world, and that's why we're here. 4 years later, after Cal's injury, my late husband, Pat, had a tumor in his neck removed. That tumor, we were told that it was benign, go home and live our lives. What we didn't know, that there was a final pathology that read high-grade synovial cell sarcoma. That got lost in the healthcare system. Pat did not get treated for over 6 months, and it metastasized, and it ended up killing him when he was 45 years old. So this session is basically seared in my heart. And this is why we're here, and that's why, Kim, Susan, Steve, Desiree are all here with us. Because when we experience a diagnostic error, and we know that around 800,000 people die from a diagnostic error, many of these people didn't die. There are even more numbers out there. The one thing that we all experience and that we all fear is that what happened to us and our family members will become invisible to the healthcare system. Because we learned through many attempts to share this information with our government, with the healthcare system, we really wanted to teach, and we found that there was no place to capture the wisdom that we had to improve healthcare. And so this is what Project Pivot is all based on. And Marty's going to kind of walk you through, that this is aligning with our thought leaders actually of the world.
Thank you, Sue. So here are our funders. We want to thank them all, especially recognize the Gordon and Betty Moore Foundation that's also funding this gathering here today. This is Project Pivot. So Project Pivot, the pivot stands for Patients Involved in Developing Outcomes Together. So we're a patient-led group that's taking another look at HCAHPS with some particular focuses. Those focuses are patient safety, diagnostic safety, discrimination and bias, and transparency. What are the things that patients and families want to feedback but just don't have good pathways to do so? That's really our goal, and we're going to focus today on diagnostic safety. This project launched in September. It's an iterative process, and you're going to be part of our gathering of data today. As Sue mentioned, we're very aligned with a number of policy initiatives that have been very prominent recently, including the PCAST report, Presidential Council for Advancement of Science and Technology, big report to President Biden, recognized in a White House event on World Patient Safety Day this year that recognized Project Pivot as an important contributor to learning and reporting. CMS, we're very aligned with the CMS quality strategy, and we're very aligned with the WHO's global work on patient safety. Sue is going to take us through kind of the model for Pivot, and then what we learned in September, and then we're going to engage you.
Yeah, thank you, Marty. And so Project Pivot, I'm not going to read all of this to you, but I just want to share kind of our philosophy and how we're going about this. First, we're starting with the patient community. We're changing the methodology. In the past, when PREMs and PROMs were all created, they started with a literature search. So it already started out biased from a literature search. So we're backing it up. We're starting with the patient community. So we've created a huge patient community, especially those from priority populations, people with disabilities, birthing people of color, older adults, as well as others, to really learn from them what are the experience and outcomes that matter to them. So this is in the phase 1, phase 2, when we're gathering this information, but not only from patients, we're gathering from industry, researchers, professional societies, healthcare system leaders, diverse patients. And so we feel that everybody has a contribution into what can end up, either on the HCAHPS and other PROMS tools or other surveys that hospitals might decide to use. We're developing those questions that patients want to answer. So you'll see it's going to go through a mapping, a prioritization process, and then by next year, September of next year, we will have various lists of questionnaire items that patients want to see, including a list that we're getting from non-patients that the patients will ultimately prioritize. And then we will distribute, disseminate, and implement, hopefully, with our partners. Our partners are CMS, HRQ, CDC, AARP, IHI, disability groups. We just have maybe over, I don't even know how many partners we have now, maybe 60 partners. And we invite you to become partners. And I do want to, go ahead.
Welcome to our funnel.
Welcome to our funnel, yes.
We're now going to give you a little bit of a sense of the convening we did in September and what we learned before we engage you. So Sue?
Yep, so we, in September, during World Patient Safety Day, we had a convening. We kicked it off with about 120 people in DC at the Johns Hopkins Bluebird Center. And lots of energy, lots of excitement. So many of the patient groups and non-patient groups, actually, even our government officials were saying, finally we have this opportunity. This window has opened up for us, all of us, to contribute to improving safety, discrimination, diagnostic safety, and also transparency by bringing in the patient community and others and say, let's imagine either HCAHPS redesigned or maybe even a whole new survey. We don't know. So what did we learn? We brought everybody together, we split them into groups, we had several kinds of exercises, and this is what we learned, what patients and families really want to report after their experience. They want to report actually that they experienced physical, emotional, psychological, or financial harm from diagnostic error. They want to report actually the events that led up to that diagnostic error. They want to report bias and discrimination, stigma due to race, ethnicity, gender, disability, weight, disease, age, and other factors. They want to report that they felt dismissed, they felt ignored, disregarded, disbelieved, stigmatized, and disrespected. They want to report the timeliness or lack of timeliness and accuracy of diagnosis, triage, and treatments, including delays from the pre-authorization process. They want to report that there were lost test results, lost specimens, misread scans, errors in medical records, and delayed access to medical records. They want to report the communication or lack of communication of their diagnosis, lack of patient education, instructions how to escalate care, and discharge planning. They want to report what was the communication between provider and actually dropped referrals. That's a big cause of harm and diagnoses. They want to report the failure to have access to current medical records and patient and caregiver engagement and decision making. And they want to report when there was failures in cultural linguistic competencies in accessibility and accommodations for special needs. Now, what I want to share was we have a big group of patients with our priority populations, and this what I'm showing you is something that cut across all patients and all priority populations. And so next year we're drilling down into various buckets, working with our various priority populations and really drilling down to those really specific questions. I do want to say one thing, because AI was out there, and some of our very forward-thinking patients are saying, we want to report if we were informed if AI was used in our care. So we're really thinking of this capturing of information of the patients of the future.
Okay, so we're going to move forward. Thank you, Sue. You've heard a lot about underreporting at this conference. One of the chief things that is underreported in the preventable harm arena is diagnostic events. And we have an expert here Divvy Upadhyay from Geisinger, who's an expert researcher in this space. So Divvy, do you want me to move your slides? Are you going to stay down there, or do you want to come up here?
No, I'm good.
Okay.
Thank you so much. So my name's Divvy Upadhyay. I come from central rural Pennsylvania, which is home to our Geisinger health system. It's been there for about 100 years. We have a system-wide program on diagnostic safety where we collect information from multiple different sources, clinicians, patients, risk. We put them through a learning process. We create improvement opportunities, lessons learned, whatnot. But I'm here today to help us just recollect, remind ourselves as to why it is important that we seek information from patients. Personally, I can tell you it's amazing that actually patient activists and patients and families that have actually suffered are right now the central convening force here. It's something naturally I think that the nation or the healthcare sector should take a lead on. And this topic is not very, it's not new, it's not rocket science. It's based on 2-3 different factors which I'll quickly mention. This is preaching to the choir here. Medicine is not black and white. Clinicians deal with a lot of uncertainty that sometimes leads to delays or misses. The way healthcare is delivered traditionally in the United States is very broken, very siloed. So communication and helping patients transition between different physicians or different settings of care, these are all factors that increase the possibilities of errors or misses. We all know that. It's not new. Even 100 years ago, you'll go and you'll find Dr. Cabot and JAMA writing about misdiagnosis and the importance of learning from it. And it shouldn't surprise you that medicine remains uncertain and nothing has changed, because 100 years later when the IOM came up with the report on diagnostic errors, it was called Improving Diagnosis in Healthcare, they reached one of the same conclusions. They said few healthcare systems have processes in place right now to identify diagnostic errors. More importantly, they don't learn from it. So collecting this information, learning from these experiences, implementing changes are all critical for achieving progress. So that said, I just want to kind of take a moment here. I'm not going to share any data. I'm just going to share one of my favorite papers on this subject and just let it sink in what these authors try to kind of tell us, how we can systematically, consistently, constantly try and learn from patients. And this is not anti-AI or anti-big data, but this is important to know despite and in spite of big data and AI. Organizations should welcome large data sets to detect and measure diagnostic errors, but they cannot lose sight of the persistent problem in quality improvement, which is data alone cannot change practice. So what can? If you can move to the next slide. I'm just reading this verbatim because just let these words sink in. Clinicians quickly learn that the most powerful stories are the ones where their patients are the protagonists, and the patient-specific feedback is the strongest motivator. So patient-specific feedback. The curation and sharing of these stories should remain a priority even with big data around us. Technology has made amazing progress. Trust me, AI will really improve the way we deliver healthcare. But the human brain has not changed one bit. The story, the patient's story, not the statistic, is what remains the brain's preferred unit of learning and the most powerful tool of persuasion. So I just wanted to give this philosophical approach here to why it's important that we seek information from patients. And I think this exercise here is about seeking your wisdom on what is it that we can seek from patients. What kind of information? Is there that one magic question or a couple of magic questions we can ask them that can help improve accuracy and timeliness of diagnosis? Thank you.
I'm going to say just a comment. Divvy, thank you very much. And something that I wanted to share is that Marty's putting up a Slido question, and we're talking about age caps right now, but actually we have this opportunity to pull in from you, our patients, everything. What are those questions we should be asking the patients that goes on either HCAPS or some other national survey or some CDC tool or whatever. Right now we have the opportunity to say, what would be those questions that we want to see on those surveys? What would teach healthcare leaders about our experiences? So what we're going to do, Marty's going to introduce this slide, but I do want to share with you that we're collecting from you all this great information. And we actually use AI to summarize the information. We're going to be doing a webinar in January. We'll announce it through IHI to tell you what you taught us. So we will feed that data back to you probably end of January. We're planning that right now. So your input really matters.
Yeah. And the poll is live. So I'm going to build a little bit more context. We asked in September patients and families to prioritize what they wanted to report. Sue just gave you some of the output from that slide. Earlier in this conference, we asked largely provider audiences that came to our session, what are the things that would be most helpful for you to hear from patients and families in your improvement work on patient safety, diagnostic safety, discrimination, and bias? And now as we move through the funnel, we're going to look for questions that we can actually build into the surveys or build into research work. And Sue, I think we've got a process that you're more familiar with than I am, but we're going to look at what questions exist now that are already validated, and then identify the gaps, and then create new questions. So you're helping us right here with that.
Yeah, and over the last 6 months, we actually started our project before we were even funded, but we reached out globally. And Marty and I both were at the WHO for almost a decade, so we have many contacts around the world. And so we started collecting already validated tools that address diagnostic safety, that address discrimination, that we in the United States simply were not using yet. So we're taking these already validated tools, and we'll be working with groups and looking at, based on what we're hearing that people want to report or want reported, we're going to see, is there already a validated tool that addresses that, and that will expedite the process. And then we'll have questions that don't have any validated tools, and we will create those, and then down the road get them into a process for scientific development and validation. Yeah. And I do want you to know that we're working very closely. Some of our collaborators are CMS, HRQ, Leapfrog, CDC, IHI, all potential users of what we are creating here today and for the rest of the year.
Sue, Divvy, everybody, we are creating great content here.
Yeah.
This is phenomenal. This is all going to go into our database. So you're at the top of the funnel, but we're going to be capturing this, synthesizing this. We use a little bit of AI to help us synthesize, and then we check on that AI to see how right they got it. And we're going to report this back, start reporting back feedback from this event at a webinar in January, correct?
Yep, correct. And then in the spring, we're going to be kind of dividing into small groups. We'll have small group virtual meetings, and again, if you want to join Pivot, you can go to PFPS.US, and there's a way to join Pivot, and you can get involved in our surveys, in working with your communities, and then we'll have a final event in September of 2025 to do the final prioritization.
Yeah. We don't have a word cloud display here. We're just having this scroll, but I'm really seeing very interesting questions, including one about whether your insurance company blocked your ability to report. We haven't really seen many questions like that suggested, so thank you for that. We have a shout out to Cal. Cal
can't walk very well or speak very well, but he is a computer wizard. And just to let you know about Cal, he's going to turn 30 in March. But he is a stand-up comedian. I say stand-up, he can barely stand up, but he's a comedian. And he's really funny. He's become very skilled at editing and doing film. So he did that for me in 2 hours. And you'll probably see more of his films in the future.
We're creating a great collection here of very human questions and also just very sort of insurance or research-related questions. But I love the one about what did you fear most when in this process. I think we must have some experts here in HCAPS or in developing these kinds of questions, because the level here is phenomenal. Yeah. What family members communicated about the diagnosis with your permission?
Yeah, and we did hear about fear quite a bit. Did you feel fear, especially from the older adult community? Fear was, a big experience that they wanted to share.
Yeah. I love the question too about family caregivers. We were talking with Lynn from AARP yesterday, because who actually is going to report on some of these priority populations? People with disabilities, older persons, it's often a caregiver. So engaging that community, which WRP
Yeah, I
does
hope you
phenomenally,
feel
is
safe.
really
Yeah.
helpful.
Great questions. And we also recognize that we're creating, that we're at the top of the funnel. So we're going to get a lot of really good potential questions that some of them may end up in HCAP. Some questions might go to another tool. We don't know. So, but this is, we're at that top. So we're really trying to, keep this really wide, and we hope that this will generate even maybe some research agendas and more work.
Was there any psychological support provided after the diagnosis is announced? I just heard from a woman whose daughter was diagnosed with a very serious cancer on a Friday, given a referral to a therapist who they couldn't reach for a week and a half because there just was no response. And that woman went home and got out of her car and laid in her driveway and just cried because she was a mother of 2 young children and she didn't know what her fate was going to be. So, I mean, these are just great questions.
Great, thank you so much. Should we go? Do we still have 3
We
participating?
have people participating. I want to get as much content as
Yeah,
we can get in
exactly.
before the end of our hour. We do have just one more slide, and that's how you can get involved. Sue, maybe you want to speak to
Yeah,
that.
I'll just speak to that.
We'll keep this live.
Yeah, and I do wanted to say that the team before us on AI, I was just thinking about what they did and how do we use AI. They said they can use AI for their complaints, and how do we bring in AI into this world as well? There's a lot of opportunity, but to get engaged with Pivot, if you are with healthcare systems and you want to have help distribute surveys to your healthcare systems, to your teams, you can join us again. There's our website will be shown on the next slide. Oh, right here. pfps.us/Project Pivot. We would love to have you all engaged. We will be, and there's a variety of ways you can get engaged. You can contribute to the creation, dissemination, analysis of surveys, focus groups, et cetera, within your healthcare system or your organizations. We're happy to work with you, and we're working with some scientific survey developers from Yale and Harvard and University of Texas. You can provide feedback on feasibility. If we start narrowing down and we start prioritizing, we want to come back to some of you and say, is this going to work in your healthcare system? I mean, we want to, we really want to develop questions that will get implemented. And we expect a little pushback, which is okay, but it'll create that dialogue that we all need. We need to get to the next level about the HCAHPS questions and about learning from patients and families.
I'm going to swing back to this because they keep coming in. Oh,
Right.
they've stopped. But again,
Okay.
I saw one there about the financial assets of a family. How much does that factor in? We're getting just things that we haven't gotten so
Yeah.
far, Sue, from other audiences.
Is there something that if you happen to be working in a health system, is there something that you are already maybe doing? Is there a question that you ask your patients around diagnostic safety? Just looking for feedback. Yes, please. No.
So we did a pulse survey for our outpatient lab. We were having some errors in testing.
Closer.
and we were having errors in labeling of specimens. So we did what we call a pulse survey. So it's short. It's not part of any official
Yeah.
survey. And we asked behavior questions. And did we ask and we didn't ask it in such a way that we were leading the horse to the water. We said, what were the things that we did before drawing your blood?
Yeah.
And patients would tell us. And then, we had an open-ended question asking, is there anything we could have done
Terrific.
better to make
Yeah.
your experience
Thank
better?
you. Thank you. Yeah. Something
Okay.
else I want to share is that we will be at the Congress in March in San Diego, and we'll be talking not just about diagnostic safety, but we're going to start drilling down into the priority populations and questions for them.
Thank you all
Thank
for
you.
coming.
Yes.
And for helping us with our funnel. Feed our funnel.
Okay, you know what? I'm going to dash because I'm supposed to.